Good evening. My name is Daniel Chancellor with the United States University, and this is for the course FNP 597, Clinical Residency and Practice with Professor Jean-Pierre Aurelius. My name is Daniel Chancellor, and I decided to do my final subnote on the endocrine system. And the reason why I chose this case was because the patient that came in had abnormal lab values when we drew his blood, and I rescheduled him to come back in a month and have a repeat of his blood work, and then also have reschedule his appointment so we could go over his blood work together. And my patient ID is JGR, and he's a 45-year-old Hispanic male patient, 5'5", 270 pounds, with a BMI of 45. The patient is married, has been a construction worker supervisor, and he does have insurance with Aetna and Medicare. And marital status, he's married. Subjective, chief of complaint, the patient states, always thirsty and urinating a lot more than usual the last 2 months. History of present illness, patient reports having polydipsia, polyuria for the past 2 months with gradual onset and progressive worsening. Associated symptoms include fatigue, unintentional weight loss, about 15 pounds, and occasionally blurry vision and tingling in the lower extremities. Patient states that he does not have any time to have any physical activity, workout, in relation to having to work long hours. Using the acronym, patient reports experiencing polydipsia and polyuria for the past 2 months. The site has been the urinary system and the GI system, as he's been increasingly thirsty. The onset, gradual onset over the past 2 months, characteristics, constant, and regardless of which fluid is taken in, he's always thirsty. No radiation happening due to no signs of discomfort. Associated symptoms have been fatigue, unintentional weight loss, numbing, tingling of the lower extremities, and the time has been progressing over time. Exacerbating or relieving factors has been when drinking water, it relieves the thirst, but also increases urination. Severity, patient reports it's affecting his sleep now because he's getting up more during the night to have to urinate. Past medical history, about 5 years ago, he was diagnosed with hypertension, and he's been treated with lisinopril 10 milligrams daily. He also obesity and bronchitis, but most of his childhood he's been healthy. Preventative medicines, he endorses using herbs for teas and also using natural herbs for inflammation and common colds. Denies of any hospitalization, denies of any major illnesses, and last menstrual cycle is not applicable in this case. With allergies, no known drug allergies, no known food allergies, no known environmental allergies. Social history. Patient's been married for 18 years, has 2 children, 14 and 16, and they live in a single home, 2-story home. The patient has smoked about 10-pack history and is trying to quit smoking, drinks 2 beers occasionally over the weekend with his friends, and as we stated, no exercise. His diet has been high carbs with frequent fast food related to the job and conveniency of the food. Reports drinking 2 to 3 cans of soda on a daily basis. For affiliation for religion, he's Catholic, attends church weekly. We covered his occupation, has worked as a supervisor construction for 15 years. And medication is taking lisinopril 10 milligrams to manage blood pressure. Multivitamin for men, takes those daily. his father and mother both had type 2 diabetes. His father died from a heart attack at 65, and his brother has type 2 diabetes. Review of systems. Constitution and patients alert-oriented, capable of making concise full sentences that are logically and organized. Patient does not endorse any negative sequences of safety at home, denies of any abuse with HENT, occasional blurry vision, denies headaches, cardiovascular, no chest pain, no palpitations, no shortness of breath with respiratory, with GI, increased thirst, normal appetite, denies nausea, vomiting, GU polyuria, including nocturia, 3 to 4 times nightly. Musculoskeletal, reports occasional numbness in the feet after long days at work. And with the integumentary, he's noticed once he gets small cuts from work, there have been prolonged healing that's been happening. Denies any psychiatric disorders, anxiety, or sleep, other mental health related abnormalities. With immunology, he denies prolonged bleeding or bruising. Blood pressure slightly elevated at 148/88, heart rate of 82, respiration 16, oxygen 98%, Romer, temperature 98.1, and a BMI of 45. Physical exam with general, patients alert-oriented, overweight, Hispanic male in no acute distress, patients independent, reliable historian, speaking clear sentences. The patient had some labs which were abnormal from last time they were drawn, with the fasting blood glucose up to 12, hemoglobin A1C of 9.3, and BUN, creatinine, GFR abnormal, and the lipid panel was abnormal as well. With the assessment, the primary diagnosis is type 2 diabetes, which is uncontrolled, evidenced by classic symptoms of polydipsia, polyuria, elevated fasting blood glucose of 212, and a hemoglobin A1C of 9.3. Also a positive family history of obesity. Differential diagnosis, diabetes type 1. This is ruled out because of patient age and strong family and absence of ketosis. Type 1 usually is in a younger age group and presents with ketoacidosis. Diabetes insipidus is the other differential. Is ruled out because of the presence of hyperglycemia. Usually in diabetes insipidus, you have normal blood glucose with a high diluted polyuria. And UTI is the final differential diagnosis. Is ruled out because of absence of dysuria frequency without urgency, and also no evidence of leukocytes or nitrates. Patient education. The patient will be educated to ensure making changes with his diet, incorporate more vegetables in a diet, and less carbohydrates that are fortified, such as breads, anything biscuity, and incorporate more vegetables as well. And today, an EKG was done to establish a baseline. Patients started on metformin, 500 BID with meals, then increased to 1,000 after a week, depending on patient's ability to tolerate the medication. Also increased the patient's lisinopril 20 milligrams daily for hypertension, renal protection, and also started a patient on a statin, atorvastatin 20 milligrams by mouth at bedtime for hyperlipidemia. We're going to provide the patient with a glucometer, test strips, lancets, and a blood pressure cuff and device to be keeping a log of his vital signs at home and bring him to the next visit so we can assess the efficacy of his medication. He also requested to begin Ozempic to help him with his glucose regulation and weight loss. A patient is also educated to ensure to walk at least 20 minutes daily for the first week and increase by 20 by the second week to make it 30 minutes times 5 days a week. And also did some education diabetic foot care, ensuring he's checking his feet. And also we're going to have a telephone visit in 1 week to review his blood readings at home and how he's tolerating the medications. For a holistic approach, collaboration of patients' cultural and background by discussing traditional Hispanic foods, how to make them healthier versions, involving his wife in the discussion as she does most of the cooking. Also acknowledging the financial concerns, provided information for diabetes programs and lower cost medication options. Gene Watson caring process also applied formation of humanistic, altruistic value systems by accepting patients' challenges with lifestyle changes, instilling of faith and hope, emphasizing diabetes is manageable with proper care, cultivating sensitive and incorporating cultural dietary preferences to ensure the patient is having enough social and family support involving his care and economic respecting the cultural norms and the spirituality, and also discussing any challenges that patient might have. And I would have patient come back in 3 months to redraw the blood work and check what the hemoglobin A1C and see his other panel. Thank you for your time.